And now we'll proceed for the next lecture from Professor Iman Sherif and talk about dapagliflozin in clinical practice. اتفضل يا دكتور إيمان.
Good afternoon, professors and eminent colleagues. Good afternoon, respected chairman. I'm very delighted to be here in the first Cardio-Renal Metabolic Forum by the AASD as one of a series of celebrations of World Diabetes Day that AASD run every year. I think this is the first in a series that would go through November and December, and I hope within 2 weeks there will be an event joined between South Canal University, my home university, and the AASD in Ismailia. I hope يعني إن شاء الله تبقى الظروف كل متاحة يعني وكل الناس تشرف. Second, I'd like to congratulate Sanofi not only on the release of the dapaglif XR, metformin XR, but on hosting this very elegant and scientific event that's not directed to one product rather than addressing all scientific issues in details. My slides will be more focusing on the maybe previous studies about the dapagliflozin, and you will find sometimes some slides repeated from presentations yesterday and today from the eminent professors, especially Professor Samir, and maybe I came across the muffled issue, and we will come across and repeat what Professor Hussein Fashawi mentioned last night. My agenda is very concise to limit significance of the numbers. The IDF Atlas, remember the WDD championship, مين اللي كان أخذوا جوائز امبارح؟ قعدوا ولا أخذوا جوائز وسافروا؟ How do the SGLT2 receptor inhibitors work, and is it only for glycemic management or what else? Remember in the diabetes in numbers yesterday, two of you I remember had one presence because they could know the answer for the question about how many adults are living with diabetes according to the IDF Atlas in 2021, and elegantly mentioned that there are more than 537 million people, adult people from 20 to 79 years of age. And mortalities are up to 6.7 globally. But there were no questions about those who are not undiagnosed. Half this number, around 240 millions, and those who are pre-diabetes. This is a great disaster. If all those were screened, those living with impaired glucose tolerance, if they are not on if they don't adopt a very strict lifestyle management and governmental and other healthcare provider sectors emphasize the role of prevention, those 541 million persons may be changing from pre-diabetes to diabetes within 3 to 4 years' time. Ironically, only 9% of the global health expenditure is directed to diabetes, though more than 3/4 of patients living with diabetes are in low and middle income countries which pay less for diabetes. Not only these numbers are what we are concerned about, but there are more than 45% of type 2 diabetes patients are already obese. And more than 50% of the diabetic patients are dyslipidemic. And the shadow of diabetes is the hypertension. 80% of the diabetic patients are hypertensive. And no targets are reached, unfortunately. Type 2 diabetes patients, 12 to 45% of the patients with heart failure have diabetes, and they are interrelated. And third of the patients with ischemic heart disease also have diabetes. What about the kidney disease? 20 to 44% of patients with type 2 diabetes have chronic kidney disease, and those with heart failure have kidney disease. You know, and the others, 76% have chronic cardiovascular disease, type 2 diabetes, and chronic kidney disease. It acts as if it's a Rubik cube. You know the Rubik cube, multiple faceted كده وتجيبها من هنا هي هنا، فهم كلهم مرتبطين ببعض عاملاها زي الروبيك كيوب. This slide had been elicited before by Professor Samir Naim Asad, that and I mentioned earlier, and unfortunately, all those numbers we are facing, only only third of the patients are achieving their glycemic targets, and overall from 1 to 12% achieved their triple goals for blood sugar and for blood pressure control and for glycemia. Though 50% of the patients are compliant to their treatment, yet they are not reaching their targets. Not because of the problem with the drug, but because there are other reasons. Maybe they were not early control. They may be early control had been established early, as been mentioned in the QBDS, that early control pays off even later after 44 years. And this was taught from the cardiologist. They are well known for risk stratification of the patients according to the lipid profile. Now the diabetologist got the idea of risk stratifying the patients according to their liability to be prone to cardiovascular disease, because what kills the patients most are the cardiovascular disease. So stratifying them into low, high, and those with established already disease, and it had been clearly shown from QBTS and other trials that glycemic control is mandatory, is pivotal to prevent microvascular complications, and it's as long as we start early, we can prevent also microvascular complications. Those who are compliant to treatment, 50%, yet only third of the type 2 diabetes patients are achieving their targets for type 2 control, and only 1 from 12 to 12% are achieving the blood pressure, both triple blood pressure, lipid control, and blood pressure control. But the problem is not only the compliance to treatment. Other reasons may exist. The natural history of the disease, beta cell by time it decline, by age. Insulin resistance increases. The fear of one event of hypoglycemia may result in the patient going into binge eating and increasing weight. Weight gain may be either due to the drug, maybe from the binge eating I mentioned just now, and maybe from the lifestyle that can't be maintained for a long time. Not all patients can be maintaining a healthy lifestyle for a long time, even doctors, by the way. And some of them have poor adherence to therapy. This is very famous, and the omnius octet had been targeted by many molecules, but it was maybe for the first time to think about the kidney and its role in the control and its role into development of diabetes. And from this figure, it has been pointed that kidneys can be a target for a drug that can decrease or control diabetes. This had been earlier presented by Professor Abdul Khaliq, Professor Hussein Fishawi, maybe Professor Ahmed Shawki yesterday, and it shows that we have two receptors, sodium glucose transporter inhibitor 1 and 2. One participates 10%, and the major reabsorption from the SGL2 and 2 receptor 2. And they reabsorb glucose, but this hadn't been presented before. The receptor, the SGL2s are there, and when the glucose, the white molecules, are passing in here, and there is no inhibitor, it is reabsorbed and goes back into the circulation. But when there is an inhibitor, which is the violet, the move molecule, you see here blocking on the SGL2, it prevents the reabsorption of the glucose, and it goes through the stream, and glucose passes through the proximal tubule to be excreted along with the urine. And it has been shown clearly that SGL2 inhibitors can cause loss of almost 70 grams per day glucose. And there is a ratio for 1 gram glucose loss equals 4 kilocalories. That's why there is weight loss associated with the SGLT2 inhibitors. For 70 gram loss of glucose, there is loss in calories up to 280 kilocalories per day. This may interpret the reasons for improvement on steatosis and improvement in weight. And to collectively point these out. Glycemic control is dapagliflozin works independently upon insulin. It doesn't cause hypoglycemia, and it works regardless of the beta cell function and activity. It causes weight loss, as I have already mentioned, and it causes through the natriuresis, which is associated with volume, accounted volume depletion, into reduction into the blood pressure. Not so marvelous, but yet it's very noted clinically. That's why SGLT2 inhibitors have cardioprotective and renoprotective effects. That's why they had been endorsed by the guidelines as early maybe as 2020, 2021, and 2022. This is from 2021. And risking going deep into the history of the patient to elicit the data regarding the history, if he's established cardiovascular event, diabetes is a cardiovascular equivalent, as we know. But if he has already a cardiovascular event before, he should be given GLP-1 receptor agonist if he can afford it, or SGLT2 inhibitors. If he had been admitted before for heart failure, or has one of the clinical syndrome signs and symptoms of heart failure, as had been mentioned yesterday by Professor Ahmad Shawqi, he should be given SGLT2 inhibitors. And if he has only multiple risk factors, as had been shown by the DECLARE by Professor Samir, he should be given SGLT2 inhibitors, definitely. And if he has diabetic kidney disease, estimated GFR over 20. Lifestyle modification is important, and this is a more detailed part of the guidelines. This is from the 2021, and here definitely metformin is there for all patients unless contraindicated due to severe GIT intolerance, lactic acidosis, recent history documented, or estimated GFR below 30. So let's look at this graph. SGLT2 inhibitors, as if it's a tap. We lose glucose. This losing glucose results in decline in fasting blood glucose and postprandial, and this results in A1C reduction from 0.7 to 1%. This is great, by the way. The QPDS learned us in 1% reduction in A1C can prevent amputations by up to 43%, prevent all-cause mortality by 21%, for example. It decreases glucose toxicity, decreases improves insulin sensitivity, and so it replenishes the activity of beta cell function. I wished my professors in the previous session had gone through the effect of on the steatosis by the effect on increased glucose, hepatic glucose production, and glucagon. And there is a metabolic shift from the carbohydrate substrate into the fat. That's why weight is decreased through the calories which are lost. And remember, this slide will be completed just in a few minutes in this blank part. The other side will be completed in a minutes. Unfortunately دكتور محمد نجيب مشي بالهدايا، فكنت لو كان موجود كنا عملناها سؤال وعملنا عليها voting. المهم انه الداباجليفلوزين انتي هايبرجليسيميك clinical effects كل what all had passed, this is physiological and biochemical, and this is lovely theories, but actually we are clinicians and we like evidences. A1C بيبقى كام؟ weight العيان بيبقى كام؟ Let's go through the clinical evidences. All the phase 2B and 3 out of 21 studies had been studying over nearly 6,000 patients received dapagliflozin, all doses 2.5, 5, and 10, and compared to around 350 comparator placebos, we had been follow-up from a range from 3 months up to 4 years. This is a very long time. In all modalities, monotherapy, add-on to orals, on insulin, compared to metformin as triple therapy, not only dual therapy, had been observed in cardiovascular studies in special populations. And let's consider special and peculiar points. Reductions in A1C for dapagliflozin in all the RCT program had shown that it could decrease the A1C from 0.5 from half to 1% in a range of A1C from 8 to 9. Yani patient started an A1C 9 can decline down to 8. Patients started from 8 can decline down to 7, and the best decline had been shown with those in the insulin and monotherapy dapagliflozin. Mostly those patients were naive to treatment or nuanced. There had been marvelous reduction in weight, especially in the monotherapy. It had been 3.5 kilograms. Less with other treatments. This had been attributed maybe to the dual medications and the bad compliance. You can see here with the insulin, it's the least decline in weight. Weight reduction could be from 1.5 kilos to 3 kilos, min baseline 80 kilos up to 95 kilos. This every kilogram loss counts. When the investigators compared dapagliflozin to metformin, they investigated around 546 patients, and they put them into 4 equivalent arms, each 137 patients, all patient type 2 diabetes from 18 years to 79 years, all stable in metformin for 2 months prior to the study, where the A1C not controlled from 7 to 10, all of them were, most of them were obese, body mass index 45. Primary endpoint was to achieve A1C reduction within 6-month treatment, after 6 months of treatment. Other endpoints was reduction in fasting blood glucose and weight reduction. And they had been classified DABA 2.5 plus metformin, DABA 5 plus metformin, 10 plus metformin, and placebo metformin. And you can see here at 24 weeks, at the shore, A1C was measured, and later on. We can see clearly that placebo, the gray line, didn't decline the A1C that much, 0.3. But there is a marked decline here at the market reduction here at the DABA 10, the dark blue line, 0.8. And not only this, it was maintained up to 4 years' time. And this pays off. This means that patient can be controlled for a longer time and needs lower adds-on. Yani need to add-on therapy may be decreased. Not only this, patients and doctor and physicians may not be patient enough to wait for the A1C. We need an evidence that the patient is being controlled now. So let's look at the reduced fasting, the fasting blood glucose. Does it go, is it reduced quickly or not? Yes. With the placebo, no market decline. But with the 10 milligram with metformin, there is a major difference. Around 24 milligram per deciliter. For example, لو patient ده جاي لك بالفاستنج بتاعه 150, for example, it can go to down 130 or 125, which is the range we need for controlling blood fasting type 2 diabetic patients from 80 to 130, as the American Diabetes Association had recommended. Not only this, there is a reduction in the body weight, which started as early as the medication started, down to nearly 2.9 kilograms with both 5 and 10 milligrams, and had been more or less sustainable over a long period of time, around 4 years, around 2 years, I'm sorry, this 102 weeks, 2 years, in comparison with the placebo, which by the time we had mentioned earlier, body weight due to the treatment, due to the non-compliance to lifestyle strategies, patients gain weight. And again, when we compare them to one of the commonly prescribed drug in the market, not only in the Egyptian market, all over, the DDP4s. This study was on 451 patients on 2 arms, compared the DABA with the sitagliptin. Some patients were on metformin or were not on metformin. Also type 2 diabetes patients, A1C from 7 to 9, above 18 years, and some had 1.5 grams metformin, others not. With primary endpoint the same, measurement of A1C at 6 months time, while other secondary endpoints, fasting blood glucose and weight reduction. And let's see, there is a marked and early decline in the A1C 0.5, but with placebo when CETA, there is no that marked decline. Also at around Sana Ella, almost 1 year, there is an increase in the A1C, but with a DABA with CETA metformin, there is maintained a decline. That's why in 2021, DDP4s were classified as intermediate efficacy. Also, SGLT2 inhibitors were classified as intermediate efficacy. This year, American Diabetes Association had upgraded the efficacy of SGLT2s from intermediate to high due to these slides and other slides. This is again regarding the A1C reduction, can be more clear from the bar charts rather than the graphs alone. And if we compared metformin to sulfonylureas, they had been compared to glipizide. Glipizide plus metformin had shown in the orange line a rapid and steep decline in the A1C, but unfortunately it couldn't be maintained to a time to 4 years, and A1C increased. But here you can see also for the weight increases nearly 1 kilogram with the sulfonylurea metformin, though the patient is on metformin, maybe due to the action of the sulfonylurea by itself. But here in the change in the weight starts early and maintained down, patient can lose up to 4 kilograms, and also the A1C reduction is maintained for 1 year. And if you count the hypoglycemic events in a 4 years time, you can see that with the sulfonylurea metformin combination, it's 10 times more than the DABA metformin. And so, yes, the metformin, glipizide plus metformin can cause a deep and rapid decline of A1C, but there will be on the other side increase in weight gain, increase in the hypoglycemic events, and maybe the drug due to the hypoglycemia, patient may not be compliant to treatment because of the fear of hypoglycemia. Now it's time to complete the other side of the slide, of this white blank slide. SGLT2 inhibitors can also cause, it acts on 2 wings, glucosuria and natriuresis, a loss of sodium that causes diuresis 40 milliliters per day, وده بيخلي في decrease في البلازما volume 5 to 10%. That's decrease arterial blood pressure, decreases the intraglomerular pressure, and this decreases the urinary albumin excretion. All these can help the renal function, decrease the pro-inflammatory markers, and decrease the plasma uric acid. This had been elegantly presented yesterday by Professor Hussein Fishawi, and he discussed the vasoconstriction of the afferent and efferent arterioles and decreased glomerular pressure, and I think he replied to a question about the synergistic effect of both RAS blockade along with the SGLT2 inhibitors cause the vasoconstriction of the afferent arterioles, and the reciprocate causes efferent vasodilatation. That's why there is intraglomerular pressure decline, which enhances the kidney function. That's why SGLT2 inhibitors exerts their nephroprotective effect by decreasing intracranial pressure, decreasing the hyperfiltration and the energy consumption. It provides ketones as energy efficient oxygen consumption, improves the erythropoiesis, and patients are no longer anemic, as we commonly see patients with chronic diabetic kidney disease or chronic kidney disease. It decreases the pro-inflammatory milieu, which is a cause for cardiovascular events as well as decline in renal function. I wished my professors from the chairperson consider the issue of the glucagon later. Regarding the cardioprotective effect, yesterday I think there had been a question regarding the multiple theories by which SGLT2 inhibitors exert their cardioprotective effect. Hemodynamic changes may be the diuretic therapy, the metabolic therapy, because the heart benefits more from the ketones as a super fuel rather than the glucose. There's decreased myocardial stretch, and there is antiarrhythmic effect for the SGLT2 inhibitors, decreased arterial stiffness and normalization of the arterial blood pressure, in addition definitely of the antihypertensive. The patient is hypertensive. There is an pleiotropic effect exerted by the decrease in the anti-inflammatory inflammatory cytokines. There is intracellular decrease in the sodium and increase in the hematocrit, decrease in the uric acid. All these can help save the myocardial function. And as presented by Professor Samir, that the DECLARE, which we had been published in 2019 in the New England Journal of Medicine, had studied over 17,000 patients. 2/3 of them had no evidence of cardiovascular events. They just had multiple risk factors. And the other third, 40% around, had established cardiovascular disease. It had been shown, this had been elicited before, that this side for both groups, those on primary prevention and those on the secondary prevention, all of them, cardiovascular death, end-stage renal disease, decline in estimated GFR, major adverse cardiovascular events, all-cause mortality, all favored the use of dapagliflozin for both groups, primary and secondary prevention. And again, most of the patients had no decline in the estimated GFR, around 2/3 or 50%, and around 70% had normal albumin creatinine ratio, and only around 7% had macroalbuminuria, and around 25% had only microalbuminuria, and estimated GFR was in 45% patient from stage 2, and the 7% from stage 3 to 5. This means that for screening patients, we have to do both, calculate estimated GFR and albumin creatinine ratio. And for those patients, not all of them had an evidence of diabetic kidney disease, but they benefited from the early prevention. And so to put on the points to try to summarize before the final take-home message, achieving A1C targets have been shown clearly over the lectures of 2 days, not only from this lecture, that they reduce both microvascular complications and macrovascular complications as long as we start early control. And SGLT2 inhibitors have shown that they have very unique mode of action. Besides their glycemic benefits, they can help with the weight reduction, with the blood pressure reductions, and it has cardioprotective as well as renoprotective mechanisms. It can be used as a monotherapy on top of other orals plus insulin, or it can be beneficial in all ways. That we can see that we have to early go for protection before there are any complications, cardiac or renal. Please don't wait for cardiorenal events so that you can start SGLT2 inhibitors. Please start as early as you can, as long as patients has multiple risk factors. And now it's time for take-home message. Dapagliflozin significantly improves glycemic control, whether monotherapy or in combination. It lowers weight significantly with no risk of hypoglycemia. That was clear from the DAPA-CKD and DAPA heart failure. Besides, it has the benefits for cardiovascular and renal outcomes. This means we are achieving the 4 pillars the EASD ADA recently joined. We are doing the glycemic control, we are working on the weight reduction, we are working on the cardiovascular risk reduction, treating the other risks plus the cardiovascular protection benefits. And it's now to thank you all for attention. And
thank you, Dr. Iman, for your elegant, simple talk. And I think that everything is clear here in your talk. I would like to ask in this stage, in the floor, if there is any question, please. Yeah.
لو سمحتي بالنسبة للدابة احنا بنديها وانس ديلي، فهل تفرق ان احنا نديها قبل الفطار ولا قبل الوجبة الأساسية ولا قبل الأكل أو بعد الأكل؟ ما تفرقش، أو لو كانت الدابة لوحدها أو لو كانت بلاس مع الميتفورمين. يعني توقيت أخذها يعني قبل الأكل أو بعد الأكل أو الصبح أو بعد الوجبة الأساسية، سواء كانت الوجبة الأساسية في الغداء أو في العشاء.
Up to my knowledge, and as long as there is a fixed dose combination that has metformin in the sample, it should be after the main meal, after the main evening meal. Especially it is an extended release metformin in this new molecule. The extended release per pharmacological action, it should be given after the major evening meal, the main big meal. Regarding the SGLT2 inhibitors, there is no clear indication whether it's before the breakfast, whether it's before, after alone, if it's single, before or after meals. But for the sake of the convenience of the patients, I do prefer give it when the patient has an access, especially in the early days, to a WC. To avoid him being annoyed with the drug, especially on the early prescription, and stopping it. Regarding to me, I don't. It has no special consideration. ما أعرفش الأساتذتي في ال chairpersons عندهم experience لازم يحب يكتبوا الصبح ولا بالليل. بيفرق.
As regard the administration of the drug, there is no evidence whether there is a change with meal or not. It depends according to the drug combinations. If you give hypoglycemic drugs, it's preferred to be before breakfast. If you want to give SGLT2 علشان البوليوريا أحسن تديها الظهر أو تديها بعد الفطار. يعني أنت ليك الحركة في الحكاية دي على حسب اللايف ستايل بتاع البيشنت. ماشي، شكرا. شكرا يا
ميرسي بروفيسور، ميرسي.